On behalf of Medicine One. The title for my presentation is A Hearty Outpouring. Presenting Mrs. V. She's a 48-year-old lady from Vellore who presented with complaints of multiple joint swellings and pain for 5 years. And the reason why she came to our hospital was because of breathlessness over 10 days. So expanding on the joint pains, it was insidious in onset. It was almost symmetrical and it was progressive. So it involved the ankles, small joints of the feet, small joints of the hand, wrist, knees, and shoulders. And there was history of early morning stiffness that was present for more than 30 minutes. And she had gone to a local doctor where they did not test for, they did not investigate her, but she was told that she had a probable rheumatoid arthritis. And the local practitioner had started her on steroids. So for the past 5 years, she's been self-medicating herself with steroids from over the counter. And the reason why she came here was she developed breathlessness that had started 10 days ago. It had worsened from MMRC grade 2 to 4 over the last 10 days. So at the time of presentation, she was breathless at rest. She had orthopnea. She also had some complaints of dry cough with palpitations, and she had some lower limb swelling associated with it. But she did not have any history of chest pain. There was no fever. There was no history of loss of appetite or weight. There was no history of any skin rashes, photosensitivities, oral ulcers, no dry eyes or dry mouth. The past history, she's a known case of diabetes, hypertension, and dyslipidemia. On examination, when she presented to the emergency department, she was tachycardic, she was tachypneic, she had elevated JVP, and there was significant pallor. Heart sounds were muffled, and on respiratory examination, there were crepitations in the left interscapular region. Because she had history of all the joint pains, she had a tender joint counts of 20 and swollen joint counts of 8. So summarizing, this patient had presented with history of breathlessness, which had worsened over 10 days, with a background history of an inflammatory arthritis. On examination, there was elevated JVP, muffled heart sounds. So with this, our differentials that we considered. So excluding the examination findings, we thought it could be a pericardial effusion, pleural effusion, lower respiratory tract infection, heart failure, or even ILD due to inflammatory arthritis. But considering the patient had come with history of inflammatory arthritis, dyspnea, and with examination, we thought she also had a pericardial effusion. The things that tied both together were probable SLE, or rheumatoid arthritis, or sarcoid. So her initial investigations, she was anemic with a hemoglobin of 7.4. Because she had history of inflammatory joint pain, we had sent for autoimmune workup. Their ANA was negative, but the RF was 4,710. Anti-CCP was also elevated, and CRP was elevated. So this was a chest X-ray where there is an enlarged cardiac shadow. ECG shows low voltage complexes. And her echo, as you can see, there is significant pericardial effusion, and it showed features of a pericardial tamponade. So we had done a pericardiocentesis. So it was a hemorrhagic, we had a hemorrhagic tap. So RBCs are 80,000, and it was a lymphocyte predominant effusion. The features fit into an exudative type, but all the infective etiology workup was negative. So coming to a diagnosis, our patient had a cardiac tamponade, etiology being rheumatoid arthritis. So coming to what I would like to highlight about this point, about this case, is that I would like to talk about cardiac tamponade and rheumatoid arthritis. So before going on to this, our patient had a hemorrhagic pericardial effusion. So the most common etiologies are malignancies, infectious, rheumatological diseases, and trauma. And among the rheumatological conditions, SLE is the most common, followed by rheumatoid arthritis and Sjogren's. So coming to pericardial effusions in rheumatoid arthritis, it is not uncommon to see pericardial effusions, pericarditis in rheumatoid arthritis. So they have found out that in cases with echo findings as well as postpartum autopsies, that at least 30 to 50% of the patients with rheumatoid arthritis have pericarditis. But on the presentation that the people come with symptoms of that is quite rare. It's only 10%. And it usually occurs only in males or highly, if the RF factor is high. And also cardiac tamponade is very rare in the presentation of rheumatoid arthritis. So literature review shows only 0.22 to 0.5% have present with cardiac tamponade. So this is a study. This was done in USA. This was a study done in 1990 where they followed up 960 patients with rheumatoid arthritis, and they found out only 5 patients had presented with a cardiac tamponade. And what they found out was there was more male predominance. So rheumatoid arthritis is actually more seen in females, but when they present with cardiac tamponade, it is seen more in males. And patients with longer duration and more extra-articular features had more chance of presenting with cardiac tamponade. The other thing they had mentioned is that patients who are started on methotrexate, the methotrexate itself can cause worsening of the pericardial effusion. This is a very old case report published in 1970. So at this time when this was published, there were only 7 other cases of cardiac tamponade in a rheumatoid arthritis. The profile of this patient was very similar to us. Ours was a 48-year-old lady. This was a 44-year-old woman who had presented with rheumatoid arthritis. However, this patient was already diagnosed with rheumatoid arthritis and was on treatment for the same. However, she had multiple flares in between. And in one of those flares, 3 years post the diagnosis, she had developed sudden onset of breathing difficulty and she presented with cardiac tamponade. So she had 3 times they had done pericardiocentesis and removed fluid. However, because the fluid kept recurring, they had to do a partial pericardiectomy. So how do we treat a patient with pericarditis or pericardial effusion in a rheumatoid arthritis? According to the American College of Cardiology, we can try NSAIDs like ibuprofen. Colchicine has also been tried. Steroids, so systemic steroid as well as injecting the steroids into the pericardial space has been tried. Immunosuppressive agents that have been specifically used for pericarditis and rheumatoid arthritis are azathioprine, anakinra, and rilonacept. IVIG has also been tried. In severe cases, in recurrent cases, pericardiectomy is useful. So how did we treat our patient? We had done a therapeutic pericardiocentesis where we removed 900 ml of hemorrhagic fluid. We had started treating her with systemic steroids, and we also started her on methotrexate, sulfasalazine, and HCQ. We had observed her for 1 week, done a repeat echo. There was no refilling of the fluid. So we have discharged her and we're planning to follow her on OPD basis. So before concluding, there are also other cardiac manifestations, but pericarditis is the most common. It can involve myocardium. There can be valvular involvement as well as electrical abnormalities. So what is the learning point? In a patient with long-standing rheumatoid arthritis, we need to have regular ECGs and echoes done. So we need to pick up pericarditis early.
Any questions or comments? Then we'll move on to the last one.